Thank you guys all for spending your Wednesday evening with us. We are from Mend, which I don't know if you guys know much about us or not, but we're a physical therapy practice and we partner with Koda. So most of us work out, like us and Kristen, the owner of the practice, work out at Koda, and we've been a part of like Koda and just partnering with Koda and kind of being a resource for the gym just to keep people like healthy and learning about how to stay healthy with CrossFit.
Off of the research study that they found that shoulder injuries are 25% of the injuries, following with low back, which we have done talks in past, so we would love to do that in the future. And then knees, which is 13%. Now, before we go into the nitty-gritty of the shoulders, it's important for you to learn the anatomy of the shoulders and to understand why this is such a prevalent condition. So we have two joints that make the shoulder, okay? We have the humerus, which is this bone here, and then our scapula. If you think about like range of motion, this is the most mobile joint in our body. This is what we call a ball and socket joint. Okay, and this will be very relevant when we go into the muscles. We also have our thoracic spine, which is where the shoulder blade connects. This is also going to be very relevant, where especially when we're doing overhead stuff, kipping motions, handstand push-ups, maybe it's actually not in your shoulder, but more like in your thoracic spine that's causing some of your issues. Here's a cool image. This is what we call a force coupled. This is just a really cool way to say that our muscles work all together so that it can help move our shoulder blade, our scapula, and our humerus up. Okay, so these are just depicting certain muscles that help move the shoulder blade up. So sometimes, actually most of the times, a lot of injuries we see is some sort of imbalance in one or multiple muscles here. So we're gonna find out like who has really good shoulder mobility, good shoulder stability to tease this out. Anything else on this that you want to share?
Yeah, and then just with the rotator cuff she's talking about, that's gonna increase like compression in the shoulder. So as we do like overhead activities, if your rotator cuff isn't very strong, you're going to lose some of this like compression that keeps it in the glenoid better, and that's going to help prevent things like subluxations, dislocations, and it creates a little more of like a stable, like a dynamic stability for the shoulder is the rotator cuff's job really. So if we're not strong there, that's where we can have risk of injury as well.
And one more thing, if we have an imbalance, I like to use an analogy of a golf ball on a tee. So again, as my shoulder is moving, ideally this golf ball is in the middle of the tee and it's moving. If you have an imbalance, like she was saying, then that golf ball can hit like a certain part of the bone, causing what we call impingement.
A third of all of our shoulder pain patients that come to Mend, that pain is actually coming from their neck or the cervical spine. And so as you can see here on these images, it kind of lists, if you can see some of the numbers, but I would say the most common is like when people kind of talk about like, oh, I have rhomboid pain, or you're like rolling out your traps all the time and you feel like you have this knot and you think it's shoulder pain, but it's often actually coming from the neck, specifically these like mid to lower cervical segments. And so something I want you guys just to know is like, if you have pain in these areas, it's worth getting evaluated, because if you don't actually treat the neck where the pain is coming from, it can become a much bigger issue, or you won't get better at all because you'll keep thinking you're treating your shoulder, but it's actually coming from your neck. So this is super common, something we see a lot. It's fairly easy to differentiate and diagnose in the clinic if you get it checked out. But again, if you're just like hitting crossover symmetry and doing all this like bandage shoulder work and you're like, man, my shoulder pain's not improving or it's worsening, that's a sign maybe it's not actually your shoulder and it could be coming from your neck.
Will had a question.
Yeah.
If you could just talk a minute for everybody about, I think that a lot of people feel that if they have something going on in their neck, they should have neck pain and not refer distal pain. So
Yeah.
talk about that.
Can you guys hear what he asked about like if you have neck pain or referred pain?
Yeah.
People can And that resistant to think that it's their neck or lower back in the case of my level white.
Yeah.
And so if you could just speak to that for a minute, just to help
Yeah.
people understand why you're saying that's such a common thing that's kind of ignored.
I think the spine, for example, like the neck and the low back, often shows up as pain in our extremities because everything that innervates like our upper extremity is coming from our neck. Everything that innervates our like gives function and sensation and strength to our legs is coming from our lower back. And so you don't have to have pain in the spine necessarily, but those segments, we have like very studied pain referral patterns from joints, from discs, from nerve roots that have been studied with like injections and MRIs. And they can find this path of like, for example, Terry, his wife came in with like calf pain and kept thinking it was a calf strain over and over. And I was like, Terry, this is coming from your back. We treated her back and it improved. Same thing with the neck. Scapular pain, arm pain could be coming from the neck. And it's just like a common referral pattern from the joints, nerves, and the disc. So I think if you just think like, I don't know where it's coming from and I should probably get it checked out, I think that's the better thing to do. But yeah, it's just our body has very unique like pain patterns. And if you don't know what those are, that's where we can help out because we've studied them a lot. If he was like here on both sides or one or the other, and he kept his back flat and didn't flare his ribs, maybe we're looking at like a shoulder mobility issue, just the shoulder joint itself. So that's shoulder flexion overhead. And then thoracic extension, the way we're going to assess it is just over a foam roller, same position, kind of mid-spine. He's going to kind of support his head and neck, and then just kind of see how much ability he has to extend. So for some people, we'll kind of go around and look at everybody, but Riley flares his ribs a lot, so then that kind of tells us he's moving from his like lower thoracic spine. What we want to see is you can keep your ribs down and still extend your mid back, which is difficult for him. Okay. Not bad. He's been working on his mobility.
You stay as relaxed as possible because the point of this is the band's supposed to provide traction. You're not fighting it, and it's almost like the band's pulling your arm. Do you feel that? Like pulling your arm forward?
Yeah.
Or what are you feeling?
We can also make it higher.
I feel it. I just don't know how far to.
You can go as much as possible. Again, let the band, so once you're here, now let that band pull your arm forward. Now you feel it. So look at his angle too. So it's one straight line. Sometimes people are at a weird angle here. We just want to make sure it's one straight line in line with your torso. I personally like doing it with being on one knee. It allows me to relax even more here.
It's better.
Better. So
I'm timing you. Hold it for about a minute. So we're going to have him stretch, and then we're going to go check his flexion again and just see if he might need more of it to really get a change. But sometimes we'll find that if we can change it quickly, then maybe if we do it a few times, like just right before a workout, we're going to improve our overhead shoulder mobility enough to get more out of like our pressing that day and our snatches, and it'll just protect your shoulder a little bit. If you don't flare your ribs, then you're touching, or you're not touching, but.
My back is touching.
Yeah, okay. All right, so then you could do both sides, but.
how are you feeling?
Look right there.
Okay, come back here. Can you get more of your chest through?
Yeah.
You might be right here. Just hold. Same thing, you can try to use your breath to try to sink into it more. See if what you did worked. Okay, we're getting better. Now we got this other category. So if you're like, I still have pain, I'm not quite in the stiffness, like all this typical stuff, then you might be in the stability category. So when we talk about rotator cuff, external rotation is coming away from your body and internal rotation's in. So your rotator cuff works not only here, but then overhead. So what we want It says the ideal ratio is 2 to 3. So that means your external rotation should be 33% of your internal rotators. When we talk about internal rotators, it includes not only subscapularis, but also the pecs and lats. All are technically internally rotate. So we just got a lot more. And that's why the internal rotation is more than your external. This, I know you guys can't really quite see it, but it's a cool research study. They basically met up with D1 football athletes, and they were trying to predict what is the likelihood that you would have a shoulder injury. Then they came up with this special test. It's called the closed kinetic chain upper extremity test. It's very a mouthful, but basically how stable is your shoulder, especially when you're trying to stress it under time. So what they found was that they did this during preseason, and then they documented the injuries, and then they found that people who did the specific test, if they failed, they were likely to have that injury come back again. So as you can see right here, less than 21 times, you're 19 more times more likely to be injured. So what Riley's gonna do is he's gonna put his hands on the tape here. He has 15 seconds. Oh, sorry, it's this. So he has to go back and forth, right, left, right, left. He has to get 21 touches.
3, 2, 1, go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. On top. 14, 15, 16, 17, 18, 19, 20. 21, 22, 23, 24.
24. Nice job.
Okay.
Good job, Riley. Crushed it. Okay. One more time. Is that okay? Mm-hmm. And push. 5, 4, 3, 2, 1. 18.5. So we could do 3. So the external was actually slightly stronger than her internal, right? So that's where we see that imbalance. It should actually be the other way around. Any pain with that one? No. Do you want me to see here?
Okay. The reason why this is still very good to incorporate is because it's working those rotator cuff muscles. Again, clinically, we tend to see this becoming like a really weak muscle. And when we're going up, we're also trying to control it on the way down.
And sooner you get it evaluated, we know what the problem is. It'll often improve much quicker versus just avoiding things at the gym or feeling like, oh, I'm just going to avoid shoulders for a few weeks. So we'd really encourage you guys just to like use the free consult, come in, get checked out. We'll let you know if it's something serious or you need referral for imaging or if it's something we can treat in the clinic and help you modify in the gym. That's really our goal, is keeping people at Koda, not having to pause their membership, enjoying the workouts because they don't have pain, and feeling like you can progress and hit your goals in the gym. So yeah, we just want to be a resource and help you guys out if you need it. So